Hello, everyone. My name is Chanel Blackwood, and I am the marketing manager at HIHIA. Welcome and thank you for registering for today's webinar, Challenges in Valuing Child Health. Today's webinar will run for approximately 60 minutes and will be recorded and uploaded on the website afterwards. The presentation slides will also be made available along with the recording. Before we get started today, I wanted to run through a couple of housekeeping items. If you're experiencing any technical issues during our webinar today, please feel free to enter your problem into the chat box and I will try to assist you as quickly as possible. For everyone on the line, if you can also add your affiliation or institution name beside your name on Zoom, that would be greatly appreciated as well. We'll be holding all questions until the end of the session where we'll open for a facilitated Q&A. I will now pass things over to Lazaros today. Lazaros, over to you.
Great, thanks a lot, Sanel. I'm Lazaros and I'm one of the conveners, and we kind of thought that perhaps this being the first seminar of the series, we could give you a quick introduction to the SIG. I've got some slides to share, only 3 slides actually. So, I wonder if people can see the slides. Great, so just a couple of words really about the SIG, mostly for people who are not very familiar with it. We are one of the youngest SIGs under HIHIA. We only launched about a year ago, and really the main idea for the SIG was to bring together people and ideas related to the topic of the economics of children's health and well-being. And having said that, we had some more specific aims. We wanted, first of all, to connect researchers and other parties, for example, stakeholders, and create a forum for them to exchange ideas. We also wanted to encourage dialogue and research, and especially the research that would take the topic forwards. We wanted to be a forum for dissemination. We wanted to talk about findings, and we are particularly keen to disseminate research that has a focus on low and middle income countries. And last but not least, we are very keen to engage, support and help early career researchers. And I've made a note there to just to say that there is an ECR event coming up on the 9th of March, and there will be some further announcements about it in due course. So that's pretty much it, really. If you wanted to find out more about the SIG, there is always the HIHIA webpage. There's lots of information about the SIG there. And we also have a Twitter account. So if you want to hear news and so like engage with us a bit more directly, then please feel free to follow us on Twitter. And last, if you had any questions, any thoughts, or even any suggestions, you can always email us directly. I'll put down our email addresses, and I'll make sure that these go in the chat box as well. So that's all from me. Thank you very much. Over to you, Oliver.
Oh, I think it's Stavros first.
Stavros.
Thanks, Les. So it's my pleasure to welcome Oliver Rivero-Arias to give this inaugural research webinar of the Economics of Children's Health and Wellbeing Special Interest Group. He's well known, I'm sure, to many of the participants here. He's an Associate Professor of Health Economics based at the University of Oxford, and he specialises in his research on economic aspects of maternal and child health, and he has particular interest in the evaluation of child health outcomes for resource allocation. Oliver's one of the editors-in-chief of Health and Quality of Life Outcomes, and he's also a member of the EuroQol group. So he's going to be presenting on the topic of challenges in valuing child health, lessons from the EQ-5D-Y valuation exercises. And for the participants who've just joined, we're asking everybody to try to keep their questions and comments until after the presentation, unless there's pressing points of clarification. So thanks very much, Oliver. Over to you.
Can you all see my screen correctly? It's great. So
Perfect.
thank you. Great. Thanks all. So thank you very much. It's a pleasure to present today's seminar, just being the first one of the special interest group. So thank you very much for having the opportunity to do this, and thanks for the welcome introduction, Stavros and the IHEA team for preparing the seminar today. So what I'm going to be discussing is not just one piece of work, but it's a program of work by myself and other colleagues that we've been working on, trying to improve and understand health valuation with the aim to estimate health gains and cost effectiveness analysis in child health. So I need to start just thinking and acknowledging that some of the work that I'm going to be presenting today is just not my own. I'm being part of some of the research teams conducting some of the work. I have led some of them, but it's been a sort of multidisciplinary collaborations over the years. And I would like to thank some of the people. I'm positive that I have forgot someone, but apologies about that. I also have a disclaimer at the start that I'm a member of the EuroQol group, being funded to do some of the work by the EuroQol group as well. But just to make clear that I will be expressing some views and probably opinions during the presentation, and they do not reflect either the views of the EuroQol or any of my collaborators necessarily. So just to make clear about that. And then funding from my funders is very welcome. So I'm going to start the starting point for my talk is I would like to place the audience in the area of what I'm going to be concentrating on, and just clarify what I'm not going to be covering. So, for instance, aspects of whether quality should be valued equally. I'm not going to be discussing, although this is indirectly important to the topic today. I'm not going to be concentrated or focusing on that area. And similarly, issues related with the estimation of child health for very young populations like neonatal and early years who's received some attention, and there are some groups around the world, particularly in Australia, who are looking at this, and I'm involved in that indirectly. I'm not going to be talking about those aspects of health valuation either. So where I'm starting is that when we try to estimate health preferences for adults, we've got guidance and robust guidance on how to do this. And what I have in my first slide is essentially two well-known books that describe some of the theoretical considerations about health valuation, and none of these books, probably the second edition of the Cost Effectiveness in Health and Medicine in the US by Peter Newman and colleagues, there is a section now that discuss child health valuation a little bit more in depth, but not to the point of providing sort of the guidance and the directions in how to conduct these studies. So in general, when we talk about health valuation, there are three considerations that we normally we need to make decisions on, and so that we start with what is to be valued, and there is an agreement generally on qualities. How is it to be valued? And in that case, we need to decide what health state descriptive system and elicitation method we're going to be using, and who is to be valued and from which perspective, essentially whose preferences and which perspective to use. In the case of adults, each of these present, both for adults and children and adolescents, they present challenges. But for adults, it seems that we have somehow reached a consensus meaning that doesn't necessarily mean that everyone agrees with what the normative positions of these or each of these challenges are. But there seems to be consensus that at least some of the HTA organizations and decision makers, they've made some decisions about what they would like to see in terms of health gains and the estimation of preferences for health estates. So what I have derived here is a bit of a traffic light, and this general consensus, I guess, in the case of adults, we can see that sort of include scientific consensus as well, is that we value QoLIs. There is a general consensus, at least on this side of the Atlantic, of the use of the EQ-5D family instruments to measure health-related quality of life. And we can estimate preferences from these, from EQ-5D health states using either TTO time tradeoff. In this case, we can also we could use potentially standard gamble. So whose preferences? We concentrate on general public. That means people above the age of 18. And more recently, also we have started to use patient preferences in the decision making. And in terms of perspective, there is a consensus that we use the adult-owned perspective, and that means that when we present a particular exercise where we need to estimate the health state, people think about their own perspective when they complete these tasks. Such different attributes that we've got here is a bit different when we start talking about children and adolescents. So in terms of what is to be valued, there is still a sort of consensus that we still want to measure QoLIs. But when we look at and when we try to understand what preference-based health state descriptive system to use, we've got a battery of measures. And in order to select one, we need to understand the psychometric properties of these measures. And we don't seem to have a consensus yet. Similarly, in terms of what elicitation method to use and whether it's reliable and valid. In terms of whose preferences, whether we need to concentrate on using the general public, that mean over 18, or the general public, including adolescents, for example, or just use adolescents. And similar, the issue of perspective is complicated even more because we need to decide and make decisions about whether we still use the adult's own perspective, child perspective, or adolescent own, or the adolescent child perspective. And again, here in this case, this is just not scientific. I don't think there's been any scientific approach and mechanism to see whether it's a consensus or not. And this is primarily me with the series of meetings and debates that I have attended and the literature where I think we agree that we want to still estimate QoLIs, and we definitely don't know the descriptive system that to use, and there is some sort of consensus on which your elicitation method to use, whose preferences, but not about which perspective. So that doesn't necessarily mean that the researchers have managed to establish protocols to derive preference-based values for health states. And here we've got a table that summarizes protocols for 4 widely used measures to estimate health-related quality of life in children. This is CHU-9D, the EQ-5D-Y, and then the both Huey instruments. And then we can see that in terms of the elicitation technique that they have used, whose preferences they have estimated from which perspective, and what sort of anchoring technique in case it's needed. And we will be covering some of these later on as well. So it's very different across the different instruments, and that means that some of the inevitable value judgments that needs to be made by researchers working in this area are made primarily by researchers. So it changes quite a lot, as you can see in the table. So what I'm going to be doing in my talk today is going to take each of these challenges about which measure, which elicitation technique, whose preferences, and I'm going to be just telling a story about either some of the work that I've done or some of the work my colleagues have done in order to understand and make probably and provide indications of way forward in terms of understanding better not the value judgment, but to inform better what value judgment to use when deciding how to measure health for children. So this is just a note. I know that most of the people in the room will be familiar with the EQ-5D instrument, and given that is the one that I'm going to be referring quite a lot during the presentation, where I just want to make sure that everyone is on the same page. So we got the EQ-5D and primarily, I'm going to be discussing the EQ-5D-Y 3 level, which is it's an instrument. It got 5 domains covering mobility, looking after myself, doing usual activities, pain and discomfort, feeling worried, sad, happy, and there are 3 levels. Go from no problems, some problems, to a lot of problems. So we can describe 243 health states. And the idea is that each of these health states we can identify with a specific number. In this case, if it's level 1 is 1, level 2, 2, and level 3, 3. So someone who responded 2, 2, 2, 3, 3, the idea is that what we want to obtain is a utility value to that specific health state. And there are challenges in when if we want to do that for children and the talk of today. So let's start first with which descriptive system, and this is the most recent review of the psychometric performance of child and adolescent preferences-based measure conducted by Donna and colleagues and others in Sheffield. And essentially, they did a very extensive systematic review where they identify all the evidence about psychometric properties of the 4 most widely used instruments to measure health-related quality of life in children. And they evaluated different psychometric properties that ranges from non-group validity, convergent validity, responsiveness, reliability, acceptability, and feasibility. And the author, and this is only selected conclusions relevant for my talk, is the authors found the heterogeneity of evidence really complicates the selection of one measure. And the reason is the CHU19 and the EQ-5D-Y, they are younger than the HUE2 and 3. They hasn't been explored as much in many conditions, and the HUE3 and the HUE2 and 3. And in the case of the EQ-5D, it's not only until very recent where we are starting to see value sets available. So the conclusion is it seems that the CHU9D and the EQ-5D-Y, they tend to have in fewer studies good psychometric properties compared with the HUE2 and HUE3. So here's an area where we're still, so that's the first point is it's the first challenge is that in terms of what measure to use, we're still got uncertainty about what's the best measure to use to measure child health and the psychometric and the different psychometric properties. So that's the first challenge where we still need to provide more, we need to do more research to understand this better, and there are people looking at this at the moment. The second one is which elicitation method to use, and the time trade-off, which here what we got is an example of the EQ-VT, which is the interface that is being widely used by the EQ-5D-5 level exercises, for example, and now the battery of exercises conducting the EQ-5D-Y. And what you've got here is the comparison is the time trade-off, where you present the participant with 2 health states. One, which is the blue one, it's in this case is a extreme or severe health state, and you live in the health state for 10 years. And then you offer the participants the possibility to live an amount of years in full health followed by immediate death. And the idea is that the more severe the health state is, participants are more willing to trade life years until indicating the severity of the condition. And this seems to have worked pretty well in terms of adults completing this exercise from their own perspective. But it's very problematic when you ask the adults to think about a child perspective. What I mean by a child perspective is that you ask the participants, okay, now I want you to complete this exercise thinking, for example, of a child of a particular age, for example, 10 years old, and then you complete the task based on that. And when we start doing this, that was our starting point around 2016 and 15 and 16, when in collaboration with Simone and others at the EuroQol group, we wanted to understand whether we could potentially use the 3-level value set with the 3-level version of the Y. And in that time that we couldn't, because of there were differences in the wording, and essentially we were looking at, and the evidence suggests that we're looking at a different instrument. But it was quite striking is that when participants completed the task from a 10-year-old, we can see that maybe not for the mild health stage, which in this case indicated by the 11112, but when we move to sort of moderate and severe, there is a tendency to have higher sort of utility values when the participants respond the task from the perspective of a child than from their own perspective. And Stefan and colleagues have recently confirmed this, that there is a systematic sort of search and the systematic difference when people complete these tasks from the perspective of a child that could potentially affect health gains and also associated incremental cost effectiveness ratios. And this has also been replicated not only by Stefan but some other colleagues. So essentially what it means is that there seems to be a reluctance to trade off when participants are presented with a perspective of the child. So why is that? And we conducted a qualitative study that was led by Philip and Donald in Sheffield, again another colleagues from Sheffield, and the idea was to present a group of members of the general public. In this case, they were adult members of the general public, around 30, in 6 different focus groups, and we used this thematic framework to get evidence of what participants and what was into people's mind, not only about interpreting the health states. In this case, the research covered other aspects like views on resource allocation, but for in terms of health valuation and the interpretation of the health states and the different perspective, it was an amazing exercise, because for me in particular, where I've been always more into the modeling side of things about analyzing the data and obtaining the results, I sort of missed why we were seeing some of the results, particularly when we were using the TTO at the start of this journey around 7 years ago. And having this firsthand coming back from the work that was done in terms of qualitative research, and there are now more people looking into the process of what goes into people's minds when they complete this task. It was very, very useful. And essentially, just to summarize, what we found is that when these people were, what happened is that at the beginning of the focus group, everyone completed the time trade-off from their own perspective and a pair comparison from their own perspective, but then from others' perspective, including the child or another adult. And essentially, what we got is that the general public respond differently when they need to think about different perspective. So they express different willingness to trade for life years, depending on their perspective. And that was fairly clear. And it was quite clear in the message that it was difficult to decide for others, particularly when it was a child. And people feel a lot more comfortable when they need to do, more acceptable when they have to respond to these tasks from themselves. So it doesn't really work well, the TTO, from a child perspective. So we could use the TTO in terms of asking adolescents directly, but we know that at a task like this one, when we start asking younger people to complete these tasks, there are issues related with the cognitive skills needed to understand risks in different points, time preferences, but also it's the ethical issues of involving notions of death and asking this sort of tasks to young people. It doesn't necessarily mean that it hasn't been done. It has been done, particularly in certain areas or in certain disease areas successfully. So we do have some evidence there. But in general, that's an exercise where it has been, they have attempted to do it in members of the general population as well, and that's the most recent one. I have found you need to change, you need to modify the time trade-off. You cannot longer ask about only 10 years. You need to go beyond, and that means that you need to change the task as we normally know it. And that's really complicated, because then you don't know whether what you're seeing is the change in the task or is because of the actual preferences. So it's not ideal. So then finally, because of this, we've seen more a move towards discrete choice experiments of stated preference methods like DCE and best score scaling in order to obtain preferences for younger people, because you don't seem to have the problems with the TTO. And this is just an example of what a DCE task looks like. So you go to health states and the participants just select one. In the case of a best worst scaling, where you've got, in this case, there are 3 types of best worst scaling. This is just a profile case, or case 2. So you go one profile of the EQ-5D-Y, and then you select which level you think is best and which one is worst. So that's just an example. So are the preferences that we are seeing from adolescents valid? And in the work that we've done in the UK, we presented what we call a sort of a control or a dominant pair, where when one of the pairs is clearly dominant at the other one. So you would expect that if people are reading the task, then they will select the dominant pair most of the time. And we can see that in terms of adolescents and adults, that was we saw. And the bottom figure, what we've got here is the distribution of choices of A and B by different level sum of a score. So the higher the sum of score, the more severity of the health state. So you would expect if it's negative, then you would choose in this case, you would choose A because it's milder than B. And we can see that the same path and the same trends was seen in both groups in our work, with a slightly more adolescents. When it's 0, it means that the severity, you can think about it, the severity of the health state percentages are similar, and that there seems to be a trend for some of the adolescents to struggle a little bit more, not to the point of invalid what the data that we had, but they did struggle slightly more. A similar study, and conducted more recently by my colleagues in Germany, Slovenia, and Spain, we're still seeing that when we've got, in here is the number of inconsistencies, similar to what we did in the UK, but in this case, they added more than one of these pairs of dominant pairs. They added up to 3 pairs. And then they look at the number of inconsistencies based on how long a cutoff of basically a minimum cutoff point for people to complete the task. So in this case, you can see that adults in Germany and Slovenia, they seem to have more number of inconsistencies compared to Spain, for example. So it's not that based on the work from both studies, it's not that adolescents the adolescents, they do worse than adults. So the evidence seems to suggest that this is not the case, and they can seem to provide preferences that are valid. However, this is an example of best worst scaling, where what we got here in a best worst scaling, you can count the number of levels, in this case, the number of levels that were selected at best and the number of levels that were selected at worst. And what you want to see is something like what you have in the adults here. It's like an iso sort of an indifference curve type of shape, where you've got, if the level is really bad, you want a lot of people to choose that as bad. If the level is really good, you want a lot of people to choose that level. But in the case of the CHU9D, which is a more complex and is a lot more complex instrument than the EQ-5D, there seems to be that for the adolescents, none of the adolescents, in terms of the worst levels, none of them really, in terms of the counts for the worst level, none of them were above 20%. And that might be a problem when the instrument or basically the instrument that the adolescents are completing might be a bit difficult. Maybe not to the point again, although the author suggested that we need to be aware of that. We conducted the same exercise both in Australia and Spain, and we did exactly the same analysis, and we didn't observe that in adolescents using different perspectives. So that's why, in our experience, we think it has to do because of the difficulties of the CHU9D compared to the EQ-5D, which is a simpler instrument. And in terms of whether the preferences are reliable, in terms of best worst scaling, we've got a paper under review at the moment where we have done a retest reliability on the data that we have for the best worst scaling, latent scale data that we collected in Spain, and we did a baseline and a follow-up. And then we just see, we're just using interclass correlation coefficient and other statistics between baseline and follow-up. And we found a moderate agreement in between both groups, very similar. So the evidence seems to suggest that that the adolescents, at least in the exercises that we've done, they seems to be providing valid preferences. So whose preferences? And the position adopted in many countries is usually general public. So, I mean, those who bear the cost of providing healthcare and those eligible to vote. But we can and we could potentially be interested in preferences for children and adolescents because they are potentially the patients who are going to experience the health state, and also are going to be the users of the technology. And given that, well, it might actually be relevant to other non-HTA uses of the instruments, for example, but given that what I have shown, that there is there seems to be evidence that that young people can complete this exercise, we might want to engage them in the process of maybe developing these value sets. But are they different? Are the preferences of adolescents different from the adults? And what we've got in this slide, this is the results of an interaction model. And the way you read here is if you see one of the bar charts and the associated confidence interval are going above 0, adults place more weight relative to adolescents. And if you go below 0, adolescents place more weight relative to adults. And what we found is that you can see there's a significant difference in terms of some of the levels for pain and discomfort, anxiety and depression, where the adults place more weight relative to adolescents. And adolescents seems to be placing more weight relative to adults in terms of mobility, for example, and self-care level 3. So there are differences in the preferences. They value things differently. That's what we found in the UK. And going back to the work that my colleagues in Germany, Slovenia, and Spain have done. In the case of Germany, we got relative attribute important difference here. The way to read this, if you go to the right, adolescents place more weight, and you have a confidence interval covering 0 or not. And then to the left, adults place more weight. So in the case of Germany, there doesn't seem to be much of a difference between adolescents and adults, but then in Slovenia and Spain, the same story was found between what we got in terms of mobility and self-care, some of the self-care and anxiety and depression compared to adolescents. So before I move into the additional challenges and just to get into the different aspects of the presentation, just to summarize so far, is that what we've seen that it's that in terms of the elicitation technique, we seem to be struggling when we use the TTO with a child perspective. That seems to be problematic. We have seen and we have explored the possibility of using stated preference methods to do that and engage adolescents and understand whether the preferences from adolescents are different than adults, and the evidence suggests that they provide valid and reliable. Obviously, that's based on our work, but because we have made those discoveries, if you want to call it, about the differences in preferences and elicitation techniques, we have also introduced some additional challenges which I would like to cover just to complete my talk today. So the first one is value sets that we obtained from discrete choice responses are in an arbitrary latent scale, and we need to anchor them to the quality scale is needed in order to obviously estimate qualities, unless an attribute of duration is included. So you can do a DC plus duration, so your resulting value set will be already on the quality scale. But that has been done with adults successfully. It hasn't, or at least I'm not aware of work using DC plus duration in the context of adolescents, or in the context of adults completing the DC with duration from the perspective of the child to understand whether the same things that we observe in the TTO happen also here. My hypothesis would be that would be the case, but I haven't seen any research of that, but there may be possibilities out there. So we can implement broadly 3 anchoring approaches. So we can anchor to a TTO value. We can, for example, we can do it to the PITS EQ-5D-Y 3333. That means the worst health state on the descriptive system. And then we can anchor the TTO value and then put it back into the quality scale using the TTO values. We can map the latent scale values to available TTO values. I mean, just doing a standard mapping approach, and we can get as complex as we want. Or if we got information available on both DC and TTO simultaneously, we can have a hybrid model in order to anchor or to estimate a latent quality scale value set. However, the empirical evidence seems to suggest that in some cases, the resulting value set that we obtain is very influenced by the anchoring approach that you're using. And that's complex and that's problematic, because that means that if that's the case, then there may be issues with the estimation of health gains, qualities, and ICERs that's going to be influenced by the anchoring approach. And we need more guidance in this area than still to clarify why the resulting value sets are different and try to disentangle the situations where this is not the case. So this is the aim of a research project that is led by David Mott, and I'm involved with some other colleagues, and it's funded by the EuroQol group, where we are trying to provide guidance and trying to understand when to use a specific, when to use specific is to try to demonstrate and provide guidance about why some the different anchoring approaches might change, and when you need to be aware of the nature of your data when you use some of these methods. So again, here, this is an area, it's a challenging area. We don't have a solution yet, but there's more work that is needed, and hopefully we will have that soon. And then the other issue is the problem of discontinuity of utility values over time. And here, this is something that it's definitely not new. It's been more in the debate and in the conversations, because we are reaching to the point where we are seeing more evidence about some elicitation techniques used in a specific context of child health, including adolescents, getting maybe a little bit away from the TTO with the child perspective. So I just want to illustrate what the problem is and how it would affect. And we do not really have a solution of this. I have a position about this. So I want to illustrate it with an example of kystic fibrosis. So there would be, what we got here is a state model. It's kind of a Markov model of a 8-year-old and older patient or a person with kystic fibrosis. And what we've got is different health states that goes from mild disease, moderate, severe, transplant, and death. So we got 5 health states. And similar to other Markov models, the idea is that the patient or the participants move over time, either stay in the same health state or it transition to some of the other health states. And obviously the person consumes healthcare resources, and they also have some qualities associated to this. And the idea is that you use these models to understand the cost effectiveness and the particular impact on cost effectiveness of introducing interventions, in this case for kystic fibrosis. So that would be a standard model. And so this is widely used by many STA organizations to make decisions these days. And if we want to, let's say, estimate qualities for adolescents with kystic fibrosis, that would be the health profile of a child or an adolescent. And each of these steps that we see is when the particular participant moves between or move across the different health states. So the person is in mild state, then it goes into a moderate state. So there's a decrease in the quality of life, and then they move into a severe state, and then finally to a transplant state until unfortunately they die. So if we have a value set, which is what this quality of life here we've got on the y-axis, so that's where my conversations today were placed primarily. So if we've got just one value set, then we can draw, and we know that the area beneath the curve is the QALYs. So we've got the QALYs for that, for this participant or series of participants, and there is no problem at all. As soon as, let's say that this participant, for example, when they are age 16, they are in a moderate state, but because they have reached the age of 16, they move into the use of the, let's say, the EQ-5D-3 level value set, which we know is done from their own perspective, and give you the evidence that we have so far. If we use the TTO with the child perspective, it has a lower value. So that means that with that has nothing to do with the treatment effect. There's nothing to do with any other factor related with the condition. It's just a purely artifact of moving from one value set to the other one. And then this would be the new transition and the new path that this participant will face. And we have a small area here that I have identified as a quality loss due to the change in value set that might be very problematic. And this is what it seems to be one of the problems that we are having, is when we are doing these economic evaluations and these Markov models, and the participant move from being an adolescent to an adult, or from a child to an adolescent. And that discontinuity in the value set can generate problems. So obviously we need to have conversations about this. And what we don't know is how this would affect in real decision making. There is very little work done in understanding the impact of any of these decisions. I mean, the selection of particular value judgments for health valuation into the final quality estimation or the quality gain. So it's not how do we address this problems, because my position is that there may be a possibility to just have one value set all the way through if you provide the correct evidence that that different value sets might not have that direct impact, or they have the direct impact, but the differences of using different value sets is not that is either negligible or not a lot, but we need to provide evidence about that. So a good way of a starting point is engagement with HTA organizations. And the normative issues that I've been discussing today, when researchers face with, when doing these exercises, they need strong value judgments when they conduct exercises for evaluation exercises for children's health states. And it was, in fact, when we did the evaluation protocol in the International EQ-5D evaluation protocol, we sort of recommend, it was open to, obviously it was just it's a baseline, it's not set in stone, but you recommend some ways. It's not that you impose, but you recommend a position to some of these values, so some of these normative decisions. And by the end of 2022, there would be 15 value sets would be using this international protocol that's been recommended by the EuroQol group. However, it seemed clear that a way forward in order to make this properly is that we need to move from working in isolation with working towards a collaboration with HTA and key stakeholders about reaching consensus about some of these value judgments. It doesn't necessarily mean that we'll agree or not, but at least it's not a decision that the researcher will face in isolation, particularly because some of these value sets is going to be used to make decisions that is going to affect a lot of people. So at the moment, then the change is that there is a strong steer now for researchers who would like to undertake these country-specific EQ-5D evaluation exercises to engage with the relevant stakeholders early in the process to discuss some of these issues before they actually engage in the evaluation exercises. And a fantastic initiative initiated by ISPOR and a nice international in collaboration with the University of Melbourne and the University of Sheffield. They did a round table. It was in October 2020. And essentially they wanted to understand, and this is not new. It's been at least within the the people who are interested on the EQ-5D-Y valuation exercises, it's been for quite a long time about the engagement with the stakeholder and how do we do it and why we haven't done it before. And they set up this essentially this roundtable with the aims of raise awareness of the challenges when valuing children's health-related quality of life and using this information in HTA. They wanted to identify areas of consensus for different approaches taken by the HTA agencies, whether to understand different agencies' perspective around the existing and development methods, whether there were guidance or not in this area, and whether they have a clear view about the normative questions. So in total, there were 22 attendees, and they represented quite a large number of HTA agencies, not all of them, but there were a lot. And this is what they found. They found that none of the HTA agencies had explicit recommendations of methods, guidance around how to measure and value children's health-related quality of life. Often lack of data on children's health-related quality of life to inform HTA evaluations in pediatric technologies. And none of them HTA agencies had a clear position or key aspects on valuation methods. And the HTA bodies, they differ on how child and adult qualities are interpreted and weighed up in decision making. So Nancy and Rosie and Donna, they've published this in Value and Outcome Spotlight recently, where it's extremely and very useful and really good reading. But that's a, for me, when I read this, it's a really good starting point, because it's a possibility to sit down with the relevant HTA and stakeholders and have these conversations and inform them with similar information that I have presented to you today. I have the conversation like that, see whether there is more that we need to do to reduce uncertainty in some of these gaps that I found today, and then reaching towards a consensus rather than, again, making some of these decisions and strong value judgments independently. So to summarize my talk today, so there are challenges to the valuation of health states experienced by children and adolescents. I believe, and I think there are many of my colleagues that believe that the best strategy to inform normative decision is to engage with the HTA organizations with the data as presented today to enrich these discussions. We clearly need to do more about psychometric properties of the instruments moving forward. And the evidence that we have accumulated seems to suggest that we cannot really know the preferences from adolescents in evaluation exercises, particularly of health state, that are going to affect them. And then there seems to be evidence and the suggesting that choice-based methods and static preference methods can be a potential alternative to matching methods, but we know that introduces more technical challenges. And we do not have robust research about how all these challenges presented today would affect health gains and resulting cost effectiveness results. And that's, I think, and that's an area where we can spend more time and spend more efforts in order to know and to be able to know more and to help more when we conduct these exercises in practice. So this is essentially my last slide, Stavros, and last.
Yeah. Thanks very much, Oliver. Thank you. That was a great presentation. Thank you. Can I ask everyone to add any questions or comments they have to the group chat? There's a comment from Scott saying that he appreciates your inclusion, Oliver, of a cystic fibrosis case study to discuss challenges in the estimation of lifetime qualities associated with a rare genetic disorder. And this is also important for the genetics and precision health special interest group. Question from Evelyn: will the slide deck be made available? Yes, yeah. I think it's going to be uploaded onto the EHIA website in the next couple of days. So please add any questions or comments that you have. Okay, so question from Stefan from Erasmus. Thanks, Oliver, for this very insightful overview of the challenges in this field. I'm seeing lots of empirical studies, but little work on the key normative issues. My concern is as follows: what happens when researchers look to stakeholders for making decisions on key normative issues, and vice versa? There seems to be the stalemates we're finding ourselves in.
Thanks, Stefan. I guess I'm not claiming that we need to tell stakeholders to just make the decisions without having the evidence. So I guess I would be comfortable if decision makers, they make the decisions based, whatever decision they make, any of these normative decisions, they make the decision based on evidence on the table. And I think that's what is missing at the moment. I know that will be difficult for all HTA organizations, particularly those where, you know, cost effectiveness analysis might not be important. But in those where it is important, I don't have a problem that decision makers make a particular normative decision if it's based on evidence and interpretation and support. Yeah.
Thanks, Oliver. Thanks. Question from Evelyn. Have any developments been made to move away from presenting the EQ-5D states in words and rather presenting the states in more pictorial form, which would make it more accessible to children?
Yeah, there's been, to be honest, Evelyn, I'm not sure where that research is at the moment. There was some of it, a few years ago, and other EuroQol members in the group might be better placed and informed than myself to answer. So I'm not sure where that actually stopped. I remember that using the pictorial introduced some problems as well. But I'm not having that work, but I don't think that is moving away at the moment from the wording of the EQ-5D states. In fairness, the work that we've done, it seems that the wording seems to be working well. Maybe if we were going to do this with earlier children, but at the moment with the work we've done, we don't see the need for that. I mean, my age group is 11 onwards. That's what I've done.
Great, thanks, Oliver. There's a comment from Wendy and Gert. One approach to the problem of multiple valuation sets returning different utilities in a Markov model is to consider this an uncertain parameter and use I think that might be a probabilistic sensitivity analysis, where one assigns a range and distribution of the utilities assigned to a given health state.
But in this case, it cannot be one distribution, right? Because we are essentially changing the mean. So we are shifting the whole, in the case of the cystic fibrosis example that I included, we are shifting the whole distribution down. So the mean will change substantially. I see what you mean about having a distribution, but I guess you mean two distributions and then see how that uncertainty. But my point is that the quality losses that you might see is an artifact of changing the value set and has nothing to do with either the course of the disease or the treatment effect. And I'm not sure whether PSA itself will sort out the problem. Yeah, but that's it's a good suggestion.
Thanks. Question from James Shearer. I wonder if the difference between adults and adolescents on pain, depression and usual activities might be due to the longer experience of adults in these domains.
Yeah, that's what we included in the discussions of the papers. I think there is clearly this issue of experience with living with, basically having experience with pain or any other the domains in the EQ-5D, and that obviously is going to affect the way you approach your preferences. And yeah, that's definitely possible. But my point is that they are, even they reflect different preferences because of the experience, then is that they are different, but it doesn't necessarily mean that they are invalid. That's my my point. I think there is one from Michelle early.
Yeah, I think you might have already answered that.
Okay.
Yeah, so I think she wrote a comment afterwards saying nothing.
Okay.
Answered a question during your presentation. Couple more questions coming through. So Laz from Warwick has asked a question in relation to whose preferences should count. It sounds reasonable to focus on taxpayers, but a non-negligible share of adults are non-taxpayers, and I guess it's hard to argue that their view should not count. Do you have any thoughts on that?
I think, well, it's similar to some adolescents. They are able to start working up to the age of 14, although I think there is some tax sort of tax, it's not tax benefits, but they don't pay the same tax threshold that we do. My views on this one is that maybe what we need to do is, at the moment, we're either suggesting, at least the conversations that we've seen, except I guess people from Sheffield, is you either do general population over 18 or you consider adolescents when you inform these health estates. But maybe the discussion is, and I've been expressed this before, maybe what we need to do is just lower the definition of general population, at least for the EQ-5D-Y, and see whether we can get a value set with, let's say, maybe general population that we define up to 12 years or above, whatever threshold we want, and see how that resulting value set is different from what we have already, and start the discussion there. I have a problem excluding the people who are going to suffer the health estate just because they are not old enough to pay taxes. That's, for me, is something there that doesn't click correctly to my mind. Yeah.
Thank you. So more questions coming through, and we don't have that much time. So Paul Schneider from Sheffield, adding to Stefan's question, my impression is that HT agencies generally have little appreciation of the value judgments implicit in the health valuation methods. At the same time, our stats and psychometric methods have reached a rather high level of sophistication. How problematic do you think that disconnect is?
The conversations, I've been in the room with some of the HTA, sort of some of the responsibles of the HTA, where we are discussing some of these issues. I think they seem pretty good at understanding what the problems are, and when you present, they don't really need to know what a specific hybrid model is, or the more sophisticated psychometric approach, as far as we explain it in a way that we can convince properly that either works or it doesn't work. And I think they're really good at that. I never, not sure exactly, obviously, your experience, but there are people who are working in NICE and some of the other HTA organizations where I find that I can have these conversations very, very well, and they are the people who are driving this within the institution, and maybe that's what is needed in this area as well. Having those people, obviously, there are people who are interested in this area and pushing that forward within the institution. So yeah, that would be my answer to that question.
Yeah, thanks, Oliver. I think we'll have to make this the last question because of the time, but a question from Giovanni and from Newcastle. Great talk. Related to one question above, is the difference between adolescents and adults justified by the literature, or is there possibly a research gap?
And the work that we presented today is related to the EQ-5D-Y, and I know that's been done for the CHU-9D. I haven't seen a lot in other instruments, so So obviously there is always room for more.
Yeah.
I think, but my opinion is that the adolescent seems to be, I mean, in terms of the difference between adolescent and adults, is that, for example, in Germany, we didn't see that difference between adolescents and adults. So it seems to be country specific as well, and that's expected because of cultural differences. And that's the beauty of having a protocol operating, because if all are using the same methodology, then some of the differences might be attributed to cultural differences, cross-country cultural differences, for example.
Thanks, Oliver. Tremendous presentation, and it sparked a lively discussion. There's sort of remaining questions and comments in the chat. I'm afraid we haven't got the time to go through those, but I wonder if maybe perhaps Chanel can send you a list of the remaining questions.
I'm happy to just write a response later on if that's needed. I mean, I know that I will definitely Stefan, and we can discuss with him very soon anyway. So yeah, I'm sure that would be fine.
Yeah. Okay. Thanks very much, Oliver, and thanks also to all the participants and also the organisers. Just to remind people that the recording is going to be made available on the IHEA website in the next couple of days, and our next webinar for this particular special interest group is going to be held on April the 12th, where we're going to have Janet Curry from Princeton University talk to us about child health and human capital. So thanks very much, everyone, and
thanks everyone, and thanks a lot for the invitation.
Okay. Goodbye, everyone.